Welcome to Grade 1 View, the podcast for future CRNAs by future CRNAs, a partnership between AANA and Beyond the Mask.
Whether you're about to graduate from a nurse anesthesia program, trying to get accepted to nursing school, or you're somewhere in between,
this podcast is a resource and safe space for all things nurse anesthesia.
We're your Season 2 host team. I'm Levi Davis.
I'm Kelsey Muir.
I'm Mackenzie Lane.
And I'm Nicholas Alexander. So grab your Mac or your Miller, turn up your flows, and get ready, because this is Grade 1 View.
Welcome back to Grade 1 View. Today's episode is all about preparing for clinical rotations, what to expect, how to show up ready, and what actually makes a difference once you're in the OR. Nicholas and I are joined by our other two senior hosts, Kelsey and Levi, who are fairly seasoned in their clinical experience, and they're going to share what it really looks like from day to day. From first day nerves and preceptor dynamics to the habits that set strong students apart.
If you're getting close to starting clinical or just want a clearer picture of what's ahead, this episode will give you practical insight, honest perspective, and a few things you'll be glad you knew beforehand. All right, so let's just start out. So tell me about your first day and what were you nervous about and what was actually accurate?
Yeah, I'll go first. My first day, I couldn't have been with a better preceptor. She is literally God's gift to my clinical site at the time. She was actually fantastic. When I showed up, she was walking me through everything. I told her it was my first day. She was like, no problem. The day went great. I was very nervous going in. I didn't know what to expect when it came to preceptors and how preceptors would react to me being new or how the OR staff would be new. And you walk in and you've been learning this stuff and you've been seeing all of it in like the simulation labs, but now it's like real and like you are like on live and you're going with a live patient here shortly. And so you're just got to trust your preparation. But yeah, I couldn't have had a better preceptor my first day.
I would say I think every clinical site probably is a little bit different in terms of how they ease you into it. I can tell you for my very first rotation, it was very casual to start out. I think you can kind of expect first day. You might not actually immediately be in the OR. In fact, you'll probably, learn where to get your scrubs. You might have to go take a picture to get your student badge. You get fingerprints for logging into certain machines or whatever throughout the hospital. So I feel like I had a good first clinical experience in terms of she, set me straight in terms of the very first part of the day is going to be just like, finding out where everything is in the hospital,
like,
how
where
to
is the bathroom?
Correct.
That is key.
Most important question.
Or where to get a coffee should you have a break. So just like the little things. So I feel like I was lucky in the sense that kind of eased into it. And the afternoon I was put into an OR with a lovely preceptor. So day one honestly was great. It was like it was actually day two that I feel like I truthfully had more nerves about because it was kind of an expectation like, all right, now you're hitting the ground running. You have everything you would need in order to like badge in, get set up, be prepared. So, you're off to the races. And I think you just at that point, like Levi was saying, kind of trusting what you've already been taught and what you maybe have already been practicing in sim lab. I don't think anybody expects you to be perfect or ready to run a full case day one. That's just not realistic. So I think if you just go in with a good mindset, open to learning and just try your best, I think there's no way you're going to have a bad first day.
Even my first preceptor, she was great and she was nice. And I did feel prepared going in, but she definitely was like the type of mom that would throw you in the deep end on your first day of swimming lessons. And so that's what happened. She's like, oh, you're doing this case. And I was like, huh? And she's like, yeah, you're going to intubate the patient and you're going to do this. And I'm like, huh? Like what? So it was definitely like I felt prepared and I was nervous, but she just threw me in. She was nice about it and she was there to support me. And she was like, I let you struggle a little bit, but I was here. The patient was safe. I was like, okay.
Was your intubation successful?
It was.
Oh, that's awesome.
It took a minute, but
okay.
It was okay.
They were
I
safe.
was shaking.
Yeah, they have the oxygen reserve. You're good.
Exactly. I could mask the patient. I could ventilate. You're going down the algorithm that you're taught in simulation and everything like that. So they were safe, but I definitely was shaky like the entire time. I would say for the first like 4 months, I was like shaking.
4 months. Oh, goodness.
Yeah, no lie.
Deep breaths.
Yes.
Yeah, I definitely want a little bit of hand holding when I first start.
I want
I'm
someone
like, I
like
want someone to
hugging me.
guide me. Yeah.
I want them to like hold both of my arms and like I'm a puppet.
They might let you struggle a little bit, but that's how you learn.
Exactly.
So tell us more about what your daily routine is like and also how you prepared for those long days.
I think for me, in terms of controlling what I can control, which is getting there early. So, my biggest piece of advice is maybe, especially that first week or first couple of weeks, you might say, okay, maybe I just only need an hour. Maybe just, factor in an additional 15 or 20 minutes because undoubtedly something is you're not going to be able to find something or you're going to need a piece of equipment. I can tell you I remember doing my first week machine check and my e-cylinder was empty. So I was like, "Oh, well, I have to figure out where to get a new e-cylinder and I have to hook this back up to my machine." So that in itself probably took about a half hour. So just all these, things that you don't foresee, could potentially happen will inevitably happen. So I think more time than you need is going to really set you up for success. And I think also if you have the capabilities, you obviously should always be looking patients up the night before if you can. If that's not possible, just again, lotting for more time, maybe in the morning and getting there even another additional 15 or 20 minutes. And I know that stinks because that means obviously less time to sleep, but that means you should just be going to bed a little bit earlier then.
Yeah, I would agree with that. The daily routine, especially when you're first getting started, is get there early. Like Kelsey said, that's the biggest piece of advice that we could give you as senior students. Now, what I did was this rule out any kind of specialty rotation because I'm getting there early, even earlier than I was beforehand. But as you get going in your clinical routine and you're getting the routine down, I do suggest that you start minimizing that time before you get there. So you're putting yourself, because when you get a job, you're only going to get paid maybe 15 to 30 minutes before the case starts. And that's when you're going to be expected to show up. So throughout your journey through school, you need to stop showing up like super early, but show up early enough to get your stuff done. But you definitely need to get that routine going. And you should be getting faster.
Yeah, I was gonna say,
Yeah.
Levi, don't you feel like you probably have actually now, you're so quick, you already can anticipate what you're gonna need for, a certain case. At least I feel like I can speak to that. I know exactly what I need to do. And I would tell people with your setups in the morning, I think it's always good to do it the exact same way every single day. So if you are someone that likes to do your machine check first, followed by, an airway setup, then pulling out your medications, getting your IV fluids together, whatever that may be. I would follow that same routine every single time. And following those like little acronyms, I know that one that we were SOAP TIM. I don't know. Did anybody else get those acronyms in terms of setup for the
Yes.
morning?
Yes.
SOAP TIM is my personal favorite.
Yeah.
Yeah. So
Is that like the most maids or?
yeah, Miss
Yeah. And then
Maids.
there's the damn it says the cool kid version. Yeah.
Ooh.
Yeah. So whatever helps you to kind of, get into your flow and make sure you're have everything kind of in order and set for the day. Like I said, but I think the biggest thing I could recommend is just making sure you do it the same way every single time. That way you're not missing something.
Yeah. Preparing, like when you're talking about your whole day's routine, if you get there early and prepare, like your whole day will, and then when you get your next case started, now you're preparing for your next case once that patient's stable and the surgery's coasting, and you're just constantly staying ahead of the game, would be like what your daily routine looks like. I prepared some quotes for you guys. So I wish I had a gong because I would like Confucius says and gong.
Please
But this
share.
goes, you don't rise to the level of your knowledge. You fall to the level of your preparation.
Ooh.
Ooh.
Gong.
Did anyone else have like chills in their bones?
Chills, shivers.
Wow. Can we get a soundboard on here?
Yeah.
Yeah. Yeah, I think that's like what I've heard so far. One, show up early / before your preceptor. And then two, just make sure you're prepared by the time they show up. Like you have a game plan for how are things, even if they shut it down, just like have that plan in place.
And just so you know, some clinical sites may ask you to reach out to your CRNAs or doc the night before. That is a great time to just be like, obviously introduce yourself, say like, this is what I was thinking for tomorrow. And then I always just kind of end with, if there's anything else that you want me to have in the room or have available, just please let me know.
Is that
And
via
I think
text? Are you texting?
I
in that?
usually text. Some
Mhm.
people say call. I personally think a text is appropriate because obviously everybody has a life outside of
Yeah.
work.
Yeah.
So, and it just allows them to kind of get back to you. And if they're like, I can tell you for my cardiac rotation, it was just myself and working with the doc. There would be times where it would be a pretty complex case, and I would just say, "Hey, would you mind when you have some time if I just called you briefly to chat about tomorrow's case?" So, open lines of communication, let it be on their terms. But I definitely think if you can text your, preceptor the night before and just kind of tell them what to kind of expect or what they are expecting of you, it just kind of sets the tone for the day.
I like that a lot.
Like Nicholas was saying, get there ahead of your preceptor. There was one morning where I woke up late. My wife like tapped me. She was like, "Hey, what time was your start time?" And I was like, "Oh my gosh, my case starts in 45 minutes." And like I walk in probably 10 minutes before the case starts, and my CRNA, who I had never been with, I didn't even have his phone number. It was my first day with him. And he was already set up, just sitting in the chair waiting for me. And he was like, "You're late." And I was like, "I know." And so I started behind negative points with this guy, and I had to regain that. Thankfully, by the end of the day, I regained that. And I was like, "I promise I'm not that person." And thankfully, I had been in this ortho room for like the last few weeks, and the people in the room could vouch for me that I'm never that person. But just setting that first foot with that guy, I was already behind because I was late. So yeah, definitely get there before.
Thanks for sharing that because I feel like a lot of people, at least me, like I would get so in my head about something like that. And yes, it's a serious thing, but it would like set me back for like weeks of like, this person's going to hate me forever. Like I can never come back from this. So it's really encouraging to know that you can come back from something like that and it's not the end of the world. And also it helps to have people vouch for you, like you said.
Well, speaking of that, so what gets you in trouble with your preceptors?
Not knowing your patient. Like if you do not know jack about your patient, like you are up the creek without a paddle. And like you are going to look so bad. They're not going to trust you. They're going to tell you to sit the case out. They're going to start questioning you more about you need to know your patient better than anybody else in that room.
I definitely agree with that. And I also think it's very evident. And I think this really happens more so when you start to kind of have more of a flow or a routine down and you start to build a little bit of confidence. I think when you are not open to hearing what preceptors are telling you or maybe showing you a different way of doing something, if you're like, "Oh no, I don't do it that way," or "I like to do things this way," I think you just have to think that whatever anybody is telling you is the best thing you have ever heard. You're like, "I never thought about that.
Oh
Thank
my
you
God,
so
that's
much."
brilliant.
That
That's
is
I'm
so
enlightened.
smart.
An epiphany.
Exactly,
The light
exactly.
bulb has gone on.
And honestly, truthfully, you might be thinking like, that actually is great. I think I'm going to use that." And then, or you might have the exact opposite reaction, like, probably not going to do that. But at least, there's other ways of doing things out there.
Yeah.
So I think it's just always being open no matter what. I don't think anybody should be set in stone in their ways and what they're doing. We just are not knowledgeable enough. We're still student nurse anesthetists at the end of the day. So that and overconfidence will definitely kill that preceptor and trainee relationship right off the bat. So just, again, be very open.
Can you guys elaborate a little bit more on what you mean by know your patient? Because like I know review the chart, review the labs, know the case, but like what should we be prepared and ready to answer if asked a question about them?
I mean, if you're looking at a guy you're doing a vascular case, this patient obviously is having vascular surgery. You have vessels all over your body. And if something has gone wrong somewhere, it's likely that there's pathology somewhere else. So if you're working on somebody's like femoral vein and femoral arteries, what is their cardiac history? What is their renal function? What was their cardiac workup? Did they have an echo? Just like kind of thinking that more critical step of like, okay, if this is what I'm dealing with, what else could be going wrong? Nothing's listed in the chart, but the patient takes protonics daily. Oh, is that is that bothering that patient today? When's the last time that GERD or acid reflux bothered them? Is it bothering them this morning? When's the last time they actually threw up? Like, knowing those things can go a long way.
Are you guys like taking notes of pre-op?
So me personally, I actually have a little sheet that I write down my patients' like past medical history. That's super important to me, obviously. Obviously, putting asterisks next to things that are very important, like if they have CAD or if they have, pulmonary fibrosis, something like that, putting pertinent labs on the back. I am also actually looking at any previous anesthetics. I think that people really underestimate that because you can learn a lot from a previous
Absolutely.
anesthetic note. Not only are you going to be able to see what they use to instrument the airway, so did they use a Mac or a Miller? Did they actually use the glide scope on this patient? What size tube did they use? What actual view of the vocal cords did they have? So that's going to give you a lot of information right off the bat about the patient's airway, right, already, and whether actually they were easy to mass ventilate, which is, as a beginner, I can tell you, is way harder than intubating.
Yeah, absolutely.
I have
Absolutely.
never been humbled so much.
Oh, yeah. Just started my peds rotation this week, and yeah, I'm like
What did I
already
tell you? What did I
failing
tell you?
again at masking.
Well, because all pediatric patients, it's not a matter of if they obstruct, it's a matter of when.
Oh, when?
So,
Absolutely.
exactly.
My first peds patient, laryngospasm, like
I
immediately.
told you that. Remember? That happened to me.
Yes, like
I
immediately.
think I needed to change underwear, but anyway.
Yeah.
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 But yeah, so previous anesthetic note, checking out what they did for the area, but then you can also see, medications that they administered and what worked really well, with that previous anesthetic. You can actually see the vitals throughout that whole case. So you're knowing like, okay, well, did this patient require a lot of pressors? Like,
Mhm. Did they give 2 of Versed in pre-op and 100 of fentanyl and a big old bolus of propofol? And then all of a sudden they're pushing a stick of Neo, had to start a Neo drip, and they're like moving on to other pressors, ephedrine and Levo. And like, it's like, oh crap, this patient couldn't tolerate all of that. And so
Yeah.
like,
Mm.
looking at those anesthetic records is huge for knowing your patient.
Yeah. So past medical history, anesthetic records, and then pertinent labs to me are like going to be the biggest highlights that I would recommend for everybody.
Well, I think this is probably the most important question here. What is the fastest way to build trust with an anesthesiologist or a CRNA?
I think this is way easier than you could think it is, and it has nothing to do with anesthesia. This is just people skills. Know people's names, call them by their names, and go out of your way to like acknowledge and introduce yourself. Good morning. Hi, I'm Levi. I'm the student nurse anesthetist here. I'm going to be working with Kelsey, the CRNA. Hello, Dr. Blank. Just doing that, you've already gained trust because you know how to talk to somebody.
That's a very good point.
I like
For
it.
for shy old me, I'm like, definitely get out of my comfort zone and
You need a
start.
name tag that just says, "Hi, I'm Nicholas."
Hi, I'm Nicholas and I'm shy.
Amongst all the other things that you are memorizing in school, memorize people's names. It really does go a long way.
Yeah. And then along with that, like you were saying, I think again, starting with communication, it's like being very open and honest. Like I will flat out tell people, like if I've never done a certain skill before or I have done it very rarely, I will be like, listen, I've done this before, but I've only done it once or twice or whatever the amount of times. But I really want to try this if you will give me a shot. So I think if you are just open and honest with where you're at in your training and what you feel confident in doing or not so confident in doing, I think that is going to go a long way. And also just like talking to them like, hey, listen, this is what I'm thinking in this situation. Would you say that I'm right in thinking this way or right if I were to do this? So when in doubt, ask lots of questions. And I think they're going to actually appreciate you more for that.
I like it.
I know some of you are, I think you're still taking classes. And so, one thing I'm just curious about is how do you balance studying with just the clinical exhaustion? Like, you're going to clinicals every day, you're preparing for cases. How do you have time to study for boards? How do you have time to study for classes if you still have them?
Well, for me, I can tell you I have had very long drives to clinical to and fro. So I just try to maximize my time. I previously, when I was in more of my didactic piece of this program, I recorded all my lectures. So when I was driving to clinical, I would listen to these like on repeat. Even if you don't do that, if that's not something, I would still suggest listening to podcasts. And there's multiple podcasts out there. Obviously, I'm not going to promote any, but core anesthesia is fantastic. I will say that.
Tanner and
I think
Cole,
everybody knows.
love you.
I know. Shout out, hey guys, if you want to talk to us, we'd love to chat with you. Anyway,
Yeah.
maximizing your time, but then also really realizing that you're a human at the end of the day, and you do need to get some sleep, and clinical performance really counts for a lot. So if when you get home, if you have dinner or whatever it is that your afternoon looks like post clinical, I think try and maintain some sort of normalcy in that sense, but then kind of try and hit the books, even if that means a half hour or an hour, if it's you have it in you. I think that's great. But I can tell you that a lot of times I might only get a good solid like half hour in because I am so mentally drained from the day, and I think that's totally acceptable.
Yeah.
There's times where I know that I will have a test the following day, and so I really need to buckle down. And that does happen too. But just recognizing that your mental capacity for learning, especially when you've had a really long clinical day, might be a little bit shortened. So just maximize time, whether it's also when you're taking a walk, listening to something, whatever you got to do.
Yeah, definitely knowing your limits on whenever you're gassed out and like you're gonna realize like you're gonna be like, man, I'm tired, but I could still study. There's gonna be days where you're gonna be like, I'm so tired, I'm not gonna retain. You'll even try to study and you're just sitting there staring at words or staring at pictures or diagrams and you're not taking it in. Those are the times where you just need to just be like, okay, take a break. What is this study session going to do for me in the long run if I'm not really actually taking it in? Maybe taking a break, taking a walk, or sleeping, like Kelsey was saying. That will actually do better for you in the long run.
I love it. I love it. I'm kind of shifting into the emotional intelligence side of clinical and school. How do you guys handle tough personalities? And if you have any examples, throw them out there.
Yeah. You're going to run into so many personalities in the OR. And that's not just your CRNA and anesthesiologists. That's OR nurses. That's OR techs. That's admin people in the OR. There's going to be people that rub you wrong like all the time. And there's a lot of times you can just brush it off. And sometimes it's really going to get to you. You just got to have enough emotional intelligence to know how to talk to people and how to know when to walk away from people. I would say, when it comes to having a difficult preceptor, just showing the eagerness to learn, it goes a long way. And some people you're not going to win over. Some people didn't want a student that day. Some people are having a bad outside the OR life right now, and they've got things going on, and the last thing that they wanted was a student today, which they should say something, but you're going to run into personalities that you can't win over, and you're just trying to get through the day, and you just got to buckle down. But a lot of the times just talking and having the eagerness to ask questions and learn from these people will kind of shape the dynamic in a better situation for you.
Yeah, I definitely agree with the personalities. I think there honestly should be a whole course on how to manage personalities in the OR because it is tough and something that I truthfully did not anticipate or that I wasn't really prepared for. So, to quote Ted Lasso, though, I feel like you just kind of have to be a goldfish. And so
Yes.
when you have like a really bad day or it's a rough day with your preceptor, you just kind of you take the lessons that they taught you and you just kind of drop that emotional baggage and then move on because it's not always going to be your best day. I think recognizing that ahead of time is important.
I can hit you with a Confucius gong moment again.
Yeah.
Be easy to teach, not hard to manage. And then another one, your attitude gets noticed before your skills do. Oh, I love that.
Ooh,
And
This
that
definitely
one,
wow.
needed
I
the
would
gong
like
for
to,
sure.
yeah. I would definitely like to expand on that one because you can have a 100% on point day, intubating, getting your dosages right, beautiful emergencies, beautiful PACU wake ups, beautiful day. And if you had a crap attitude, or if you were cocky, or if you were going back and forth and fighting with a preceptor or having words with the OR nurse, that part of your day just got minimized to about 5%, and people are going to remember that 95% of your bad attitude. And
Yeah.
that goes a long way with dynamics too, because then people are going to start chattering about, hey, did you hear about that SRNA? Like went back and forth with so and so. Like that's what you're going to get known for. So it's a huge thing to kind of set yourself up for success.
And unfortunately, I think just because of the position that we're in being students, I think you kind of have to kill them with kindness.
Yeah.
I know that there was times that I was with preceptors and I don't believe of any fault of my own. They just did not seem very eager, we'll say, to want to precept me or very ecstatic. And so I said, thanks for your patience today. Thanks for teaching me X, Y, and Z. And I feel like it was interesting when I said those things, they were like, oh, yeah, of course. And then I feel like maybe there may have been a hint of remorse on their end, that they felt that they knew that they were maybe not the nicest to me and felt a little bit bad. Or maybe I say that to myself just to make myself feel better. But at the same time, I think it's just, again, like I was saying, be a goldfish. You just have to let it kind of roll off your back and move on, because there are going to be some really, really amazing preceptors out there that are just really going to help you along this journey and make all of this world worthwhile. So
absolutely. And I would say that's the majority of the time. The bad, negative stuff is a very small portion, at least from my experience.
Nice.
Yeah,
Good
because
to
I
know.
think for me, that's like one of the biggest things going into clinicals is the preceptor dynamics and having to, because I think just our teachers try to prep us for the worst. So if anything happens, it's like we're prepared for it. But yeah, for me, that's like my biggest fear is like, what if they're mean to me? And I thought about like working out and just getting super jacked so no one would be mean. I'm like, they're like, I'm not gonna mess with this guy with a huge. Yeah.
Nicholas is like literally gonna Hulk out and just turn green.
Like they're not gonna mess with the guy with huge biceps.
Touche.
But
Yeah, right.
But I don't know. Yeah, I just that's why our teachers they're telling us like don't engage in certain conversations that are happening.
Right.
We had one teacher that's like, I mean, you might have to be a Republican or a Democrat for that day and just like not challenge them, don't argue with them. You're just smiles telling them how awesome they are. So
Yeah.
And everyone does everything different. I think so. This is a huge thing that for advice from me is my first week, 2 weeks, I felt so confident. Like I missed intubations. I was learning, didn't know all the questions I was being asked, but my confidence level went up. And then when I started recycling through preceptors and now they're expecting me to do things and like have the flow, but it wasn't their flow. And like learning each preceptor's way of doing things. And like there are some preceptors that act like certain things you do are like you are summoning the devil from hell into the OR on this patient. Like I'm not kidding. And it's like the most frivolous thing in your mind, but to them, they've been scarred by something along the way that made them and put that as their habit. And they think every person should do that as their habit. And you're going to come back to that preceptor and you're going to miss that opportunity and they're going to be mad with you. And like it's navigating that was probably the hardest thing for me. So like I said, like the first 2 weeks I felt confident, and I'm talking like month 1.5 to like 5. That was probably the hardest part of anesthesia school so far. I'm not finished yet, but that was probably the hardest time, was coming back up, relearning how everybody does everything and that everybody does things differently, and that anesthesia is an art and everybody colors differently, but everything's beautiful. Some things are wrong, but some things are right, and everybody does things different.
Yeah. I mean, you're going to find out that there's a million ways to tape a breathing tube, and they are all right.
And the other ones are all wrong.
That's another that's another one where you're just like, oh, okay.
I never thought about that before.
Take
That's
it,
brilliant.
you're doing great already, Nicholas. See, you got the answer.
You're ready. You're
Oh,
ready.
man, nobody's taught me like that. Like that's cool. I like that idea.
Yeah. Always a great answer.
There's a lot of gaslighting.
You're the smartest CRNA I've ever worked with before.
Oh, man.
Teach me your ways, oh wise
Me and
one.
Kelsey are about to get reamed when we go back to clinical.
If you're listening.
I know.
Yikes.
Oh gosh, all their secrets. I have a few like rapid fire questions if we want to Just like short answer
Sure.
things.
Love it.
Yeah, let's do
What's
it.
thing to always bring with you to clinical? One thing.
Stethoscope.
Good attitude.
Love it.
Yeah.
All right. What's one phrase that earns respect in the operating room?
I would say hello or introducing yourself to everyone.
Wow, that's amazing. Okay, teach me. Teach me. Like,
Okay.
teach me. There we go. That's what I would say.
Teach me. Cool. One thing to never say.
I know. Oh my gosh. Do not say those two words. Do not like say, oh, I know. I know. Or like a preceptor is trying to tell you something. I know. That's where you start looking cocky.
It's like, just say thank you. Just say
That's
thank
a
you.
good one. Other than I know, I don't know if I could really say anything not to say. I guess I would probably maybe put it as like never apologize for being safe or kind of like taking your time,
Mm.
especially with like emergence, because I feel like everybody looks at you towards the end of the case and maybe they're not waking up as fast as, everybody in the room would like because they want to move on and get the next case going. But
You're
I
sitting there
know
looking
that
at a .2 Mac and like
yeah,
0.4 Stevo, and you're like, okay, come on.
but my preceptor was like, "Listen, they had 2.5 hours to do what they needed to do.
This is true.
We are going to take the 10, 15 minutes to wake our patient up safely." And I was like, that's really valid. So I'm going to do it right. I'm going to do it safely. I'm going to make sure that we're good. So
Yeah.
I think, never apologize for kind of being safe, I guess.
You're not going to get in trouble for somebody staying intubated too long. You're going to
Correct.
get in trouble for pulling that tube when they're staging, and now you're having a problem. Now you can't mask, you can't ventilate. Now you're having a problem.
Yeah.
And they're all going to point at you. They're like, oh, well, they took it out too soon.
It's like, you've been staring
Always
at
blame
me.
always blame the student.
And anesthesia. So the
And
anesthesia
anesthesia,
student
yeah.
is like a double whammy.
Oof. Have you guys, this is not one of my rapid fire questions. Has anyone ever blamed you when something wasn't your fault?
I don't think so. I don't think there's ever been an incidence where like a bad outcome or anything like that. I would say the one thing that I've done is like you'll have preceptors that are like heavier hitters with their meds, and your patients will be a little too sedated going out to the like PACU, and like they'll still need like an airway or they'll need some kind of intervention in the PACU, and it kind of does get thrown on you at times because you're the one that was managing that patient, even though your preceptor was kind of pushing you in the
Yeah.
direction that they wanted you to.
Yeah, makes sense.
I don't know if I've had anything pushed on me, but yeah, I definitely agree. Probably the sleepiness factor, like, oh, maybe we should have reconsidered giving, X, Y, or Z, something
Oh.
like that.
Yeah.
Oh my gosh.
Anyway.
And your reversal, that will make you your muscle relaxant reversal. If there's any advice as well, here's another tip. Carry a vial of Sugamidex in your pocket when you go check on
Nice.
your
Good.
patient.
Noted. Very noted. Okay. Good to know. Back to the rapid fire. Sorry. One habit that separates top students. We've talked about a lot, but the main one.
I think it's just kind of recognizing what your current capabilities are and just what your areas of growth are. So I think that's going to be the biggest thing. I think people need to recognize that it's not a matter of like if you fail in clinical, it's just a matter of when. You're going to have a lot of failures, and it's honestly it's going to happen probably every week. I feel like every week, almost probably even every day, you get humbled by something, and that's what makes it such a great profession, and a really hard profession at the same time, and very rewarding. So just knowing that, okay, there's always going to be something that I need to continue to progress and work with. And yeah, as long as you're honest with yourself and with your preceptors about that, I think that's what is going to make you a standout SRNA.
Yeah, going off some of the points you made, you're going to make mistakes. You're going to get corrected a lot, and you're going to have those L's. Just like taking those L's in, like it feels like you could have a day where you're having wins all day. And then you have one mistake, and that's going to eat you alive on your way home. And like you just got to let that go because you had all of those other wins that day. And there's some days where you're going to have a lot of losses and a lot of fails and you're going to feel bad about yourself, but you got to brush that off because guess what? You got to get up in the morning at whatever God given hour in the morning to get to the OR to be there for your next patient. If you're still holding on to stuff from the day before, take the lessons you've learned, but leave the emotions out of it, because this is just all data you're collecting to build your practice. One habit that I wanted to mention is following up. I feel like the top students or even the top CRNAs that I'm with follow up, whether that's after 15 minutes, if you're going to pre-op to get your next patient or interview your next patient, walk back through the PACU. See what your anesthetic plan looked like. Is that patient having vomiting? Are they still having pain? Is the PACU nurse controlling their vitals? And did they have any issues? Are they still on drips? Like, just following that up will give you so much information about your anesthesia that you gave that you can continue forward with. Following up with, if you didn't know an answer to a pimping question that they gave, that somebody was asking you, come back the next day with that answer or a reference article and follow up with that person and say, hey, Dr. Blank, I didn't have the answer to this question. This is my follow-up with you. Now I understand it. Just following up makes a huge difference in people's opinion of you.
Yeah, I think also might be good too, kind of with that, is just kind of having a clear set of goals set with your preceptor at the beginning of the day. Saying like, hey, today I'm really working on induction. Like, I want to get that down pat, or case management, whatever it may be, is like having a clear goal for the day. And I think if you can kind of communicate with that with your preceptor, it's going to make for a nice day. And I think they're going to be pretty impressed that you're starting to recognize like areas that you're trying to achieve. So
like even day one, a goal of mine, and this is what I told people in the lower classes of mine at my school. Day one, my goal is to see an airway. I don't have to intubate it if I can't, but if I can put a blade in somebody's mouth and see the airway, goal achieved. Like, I made my goal for the day, check. Like, do I do all these other things? Great. But I made that goal, and making those goals, like Kelsey's saying, it helps build your confidence too.
I like that. Tangible and feasible things. I like it.
Keep it simple.
Yes, keep it simple. My teacher says, keep it simple, stupid.
Yeah, kiss
Mhm.
All right. That was incredibly helpful. And I'm not going to lie, I feel both more prepared and just the right amount of humbled. If you're listening and about to start clinical, I hope this gave you a clear picture of what to expect, but more importantly, some confidence that you'll grow into it. No one starts out feeling ready. You figure it out by showing up, staying teachable, and putting in the reps.
Thank you for being honest, for sharing the highs and the hard moments, and for giving the kind of advice that actually sticks. And to everyone listening, if this episode helped you, share it with someone who's about to start clinical too. And we'll see you all next time on the Grade 1 View.